Infective endocarditis. It is an infection that causes vegetation on endocardium. Most friable vegetations are seen here with high risk of embolization. Infective endocarditis is due to microbial infection of a heart valve. It may be native or prosthetic. The lining of a cardiac chamber or blood vessel or a congenital anomaly. Infective endocarditis is due to a microbial infection of a heart valve. It may be native or prosthetic, the lining of a cardiac chamber, or blood vessel, or a congenital anomaly. Classification of infective endocarditis. It can be divided into native valve endocarditis, prosthetic valve endocarditis, and endocarditis in IV drug abuser. Mitral valve is most commonly involved, followed by aortic valve in native valve endocarditis. In prosthetic valve endocarditis, it is reverse. Aortic valve is more likely involved than the mitral valve. Now let's come to the pathophysiology of infective endocarditis. It occurs at site of pre-existing endocardial damage. But infection with virulent organisms, example Staphylococcus aureus, can cause endocarditis in a previously normal heart. Infective endocarditis occurs at site of pre-existing endocardial damage, that is, when the endocardium is already damaged, it can occur at that site. But infection with highly virulent organisms like Staphylococcus aureus can cause endocarditis in a perfectly normal heart. Also, Staphylococcus endocarditis of a tricuspid valve is more common complication of a IV drug abuser. Staphylococcal endocarditis of a tricuspid valve is a common complication of IV drug abuser. Many cardiac lesions are vulnerable to endocarditis, particularly areas of endocardial damage caused by high pressure jet of blood, such as left side of the heart as in VSD, valvular incompetence as mitral regurgitation, atrial regurgitation, and distal to constriction in correctation of aorta. What it means is, whenever there is a VSD, the blood flows from the left side of the heart to the right side of the heart with a force. In that force, the blood hits the septum, causes abrasion in that area of the septum. Because of that abrasion, platelet and fibrins deposit in that area. This platelet and fibrins serve as an adhesion site for bacteria, which will later form vegetations and lead to infective endocarditis. Remember, patients with ASD are at low risk for developing infective endocarditis because blood doesn't flow at much faster rate in atrial septal defects when compared to ventricular septal defects. The infection tends to occur at sites of endothelial damage because they attract deposits of platelet and fibrins that are vulnerable to colonization by blood-borne organisms. The avascular valve tissue and presence of fibrin and platelet aggregates help to protect proliferating organisms from host defense mechanism. I'll repeat, the avascular valve tissue and presence of fibrin and platelet aggregates help to protect proliferating organisms from host defense mechanisms. When the infection is established, vegetations grow and may become large enough to cause obstruction or embolism. Adjacent tissues are destroyed and abscesses may form. Now let's talk about microbiology of infective endocarditis. Most of the cases are due to staphylococci and streptococci. Most virulent are Staphylococcus aureus, which can infect normal valves also. The viridans group of streptococci are commensals in the upper respiratory tract. The viridans group of streptococci are commensals in the upper respiratory tract. These are less pathogenic. that may enter the bloodstream at the time of dental treatment and are common causes of subacute endocarditis on deformed heart valves. Streptococcus viridans acts on deformed heart valves and cause infective endocarditis, whereas Staphylococcus may attack normal valves also. Other organisms, including Enterococcus fecalis, Streptococcus bovis, may enter the bloodstream from the bowel or urinary tract. Drug abusers in endocarditis is common in young males. Tricuspid valve is involved in most of the cases. Pulmonary emboli or pneumonia is common in tricuspid valve endocarditis. Staphylococcus aureus is a highly virulent and invasive organism, usually producing florid vegetations, rapid valve destruction, and abscess formations. Postoperative endocarditis after cardiac surgery may affect native or prosthetic heart valves. Postoperative endocarditis after cardiac surgery may affect native or prosthetic heart valves. Lifelong antibiotic treatment may be required for such patients. Now let's come to the clinical features of infective endocarditis. Remember the mnemonic from Jane, where F stands for fever, R stands for Roth spots, which are oval retinal hemorrhages with clear pale center. O stands for Osler nodes. M stands for murmurs. J stands for Janeway lesions, which are small non-tender hemorrhagic lesions seen in palms and soles. A stands for anemia. N stands for nail bed or splinter hemorrhage, which are subungual dark red streaks seen in endocarditis, commonly after trauma. E stands for emboli. Now let's come to the investigations. Blood cultures is positive in 95% of the cases and is the crucial investigation because it may identify the infection and guide the antibiotic therapy. 3 to 6 sets of blood cultures should be taken prior to commencing therapy and should not wait for episodes of pyrexia. Aerobic and anaerobic cultures are required. Echocardiography is the key for detecting and following the progress of vegetations, for assessing valve damage, and for detecting abscess formations. ECG may show the development of AV block and infarction due to emboli. Chest X-ray may show cardiomegaly. Diagnosis of infective endocarditis is made by modified Duke's criteria. It consists of 2 major criteria and 6 minor criteria. The 2 major criteria include positive blood culture, typical organism from 2 cultures, persistent positive blood cultures taken more than 12 hours apart, 3 or more positive cultures taken over more than 1 hour duration. Second one is endocardial involvement. Positive echocardiographic findings of vegetations, new valvular regurgitation. Minor criteria include predisposing valvular or cardiac abnormality, IV drug misuse, pyrexia with a temperature of more than or equal to 38 degrees Celsius, embolic phenomenon, vasculitic phenomenon, blood culture suggestive of organism growing but not achieving major criteria. Suggestive echocardiographic findings. Whenever there is 2 major or 1 major and 3 minor or 5 minor criteria, it is suggestive of definitive endocarditis. But whenever there is 1 major and 1 minor or just 3 minor criteria, it is suggestive of possible endocarditis. So how do we treat infective endocarditis? Cure of endocarditis requires eradication of all microorganisms from the vegetation. Microbial drug regimen must be used in enough concentration and duration to sterilize the vegetation. Any source of infection should be removed as soon as possible, like a tooth with an apical abscess should be extracted. If the presentation is acute, flucloxacillin plus gentamicin is given. If the presentation is subacute, benzyl penicillin plus gentamicin are preferred. Remember, if the presentation is acute, flucloxacillin plus gentamicin is given. If the presentation is subacute, benzyl penicillin plus gentamicin are preferred. In those with penicillin allergy or prosthetic valve or MRSA, triple therapy with vancomycin plus gentamicin plus oral rifampicin is considered. In those with penicillin allergy or prosthetic valve or MRSA, triple therapy with vancomycin, gentamicin, and oral rifampicin is considered. How much time should we give an antibiotic to a patient? A 2 to 6 week regimen is sufficient. Cardiac surgery is advisable in a substantial proportion of patients, particularly in those with Staphylococcus aureus and fungal infections. Antimicrobial therapy must be started before surgery. What is the dental relevance of infective endocarditis? Maintain proper dental hygiene and gum health. Have regular cleanings and follow your dentist's advice about gum health. If you experience gingivitis, ask your dentist about steps you can follow for better gum health. Now let's come to the prophylaxis of infective endocarditis. Whenever a patient visits your dental clinic for a surgery, give a single dose of the following regimen 30 to 60 minutes before the surgery. Oral amoxicillin is the standard drug of choice for antibiotic prophylaxis for oral cavity procedures in adults at moderate to high risk of infective endocarditis. Oral amoxicillin is the standard drug of choice for oral cavity procedures in adults at moderate to high risk of infective endocarditis. In high risk cases, ampicillin can be added, IM or IV plus gentamicin can also be given. In high risk cases, ampicillin can be added, IM or IV plus gentamicin can also be given. Cefazolin may be used if the patient is allergic to penicillin. Cefazolin may be used if the patient is allergic to penicillin. For genitourinary procedures, ampicillin with gentamicin is used. For genitourinary procedures, ampicillin plus gentamicin is used. Vancomycin plus gentamicin can be used for patients allergic to penicillin. Vancomycin plus gentamicin can be used for patients allergic to penicillin. With this, we complete infective endocarditis. But there is a particular topic which I would like to share, that is Libman-Sachs endocarditis. This frequently appears in the competitive exams. What is Libman-Sachs endocarditis? It is an endocarditis of systemic lupus erythematosus. It is a characteristic endocardial lesion of SLE described by Libman and Sachs. It consists of a wart-like lesion associated at the angles of the AV valve or on the ventricular surface of mitral valve. It consists of a wart-like lesion associated at the angles of the AV valve or on the ventricular surface of the mitral valve. It can also be seen in the pocket of valves. Hemodynamically significant regurgitation is rare. Hemodynamically significant regurgitation is rare. Thank you.